Yes, ma'am. We are live now.
Good evening, doctors and participants. Myself, Nidhi Mishra, on behalf of High Glance Laboratories, welcome you all to today's webinar on the two interesting topics by renowned speakers. The first topic is Diagnostic Dilemma of Hypertension by Dr. Ajay Sharma, Senior Interventional Cardiologist and Professor, Department of Cardiology, Gandhi Medical College, Bhopal. And the second topic is exercise prescriptions in diabetes by Dr. Vishal Kastwar, a leading diabetologist from Jabalpur. The coordinator for the today's evening is Dr. Abhishek Srivastav, a leading endocrinologist from Jabalpur. Over to you, sir.
Thank you. I suppose I am the first speaker, but I think Dr. Abhishek, would you like to say something before we begin, or shall I begin?
No, we should start it.
Okay.
I haven't received the CVs though, so that I am unable to introduce you actually.
Yeah, no, it's perfectly okay. She has already introduced us. And
yeah, that's fine. That's fine. Yes.
Good evening, all. It is indeed a pleasure to be amongst all of you during this corona pandemic. Actually, this is Christmas Eve, but still we are online and having some good discussion about exercise in diabetes, which Dr. Vishal Kastwar will be deliberating a lecture on, and myself on diagnostic dilemma in hypertension. Allow me 30 seconds for screen sharing, please. Can you see my screen? Hello?
Yes, sir.
Yeah, sure. Please.
So, as we know, it is very easy to label a patient as hypertensive. But the question is, what criteria is ideal in present scenario and which modality should be preferred? And which is the better drug for hypertensive patients to start with? Which is a monotherapy with a single drug, or a single pill combination therapy, or multiple drugs? So in India, hypertensive scenario is staggering. Almost 33 to 40% of urban population is afflicted with hypertension, and 15% of rural population is also affected with hypertension. Almost 1/4 of India above 25 years of age are suffering from hypertension, whereas global average is around 30%. So if we look into the hypertensive scenario, 50% of all stroke deaths and almost 40 to 60% of cases of CKD are accounted for by hypertension, and 1/4 of all coronary heart disease deaths are due to hypertension. So are we really open to change? What should be the diagnostic criteria and which drugs to use? So the challenges faced by doctors are two: which diagnostic tool to rely on, and whether to start with monotherapy or combination therapy from the start. A study revealed that there is huge discrepancy in clinic blood pressure measurement and home blood pressure measurement. 42% of non-hypertensive patients are either misdiagnosed or miss the diagnosis for hypertension. This happens in a way that 24% of the patients are misdiagnosed because of white coat hypertension, as we know, due to labeling of hypertension in our office clinic setting, and 18% of the patients miss the diagnosis because of masked hypertension. And overall, in global scenario, 70% hypertensive patients are uncontrolled despite being on treatment. If globally, only 1 of every 7 people have their hypertension under control. So 3 are unaware that they have high blood pressure. 2, they are aware, but they are untreated. And 1 is aware but untreated, and 2 of them are treated, but they are not very well controlled. So only 1 out of 7 are adequately controlled for their hypertension. So right management of hypertension starts with correct diagnosis of blood pressure. Criteria for hypertension differs based on the diagnostic tool which we are using. If you are taking into account office blood pressure or clinic blood pressure, then systolic 140 or more or diastolic 90 or more is labeled as hypertension. And if we are taken into ambulatory blood pressure into account, 24-hour average of 130 or 80, more than that is a patient is hypertensive. And if into the ambulatory blood pressure, if daytime average is being taken, then 135, 85 is hypertensive. Whereas a nighttime average in ambulatory blood pressure, even if systolic is more than 120 and diastolic more than 70, then these patients are labeled as hypertensions. Important is home blood pressure monitoring. If systolic more than 135 and diastolic more than 85, then these patients are labeled as hypertension. So again, is stressing the fact that ideal way of blood pressure measurement is out of office. If possible and available, the diagnosis of hypertension should be confirmed by out of office blood pressure measurement. And there are two out of office blood pressure measurement methods which have been used. Most ideal and most easy way is home blood pressure monitoring, and second is ambulatory blood pressure monitoring. Home blood pressure monitoring reclassifies office measurement and has better prognostic outcome compared to office BP monitoring. Compared with clinic blood pressure monitoring, home blood pressure monitoring values are usually lower, and the diagnostic threshold for hypertension is 135/85, which is equivalent to office blood pressure of 140/90. Compared with office blood pressure, home blood pressure monitoring provides more reproducible blood pressure data, and that is important, and is more closely related to hypertensive mediated organ damage, particularly left ventricular hypertrophy. Home blood pressure monitoring better predicts cardiovascular morbidity and mortality compared with office blood pressure monitoring. So if we look into the new developments in the 2020 International Society of Hypertension practice guidelines, it has redefined hypertension and advocated initiating treatment with a single pill combination therapy, and has advised for wider out of office blood pressure measurements and for the lower blood pressure targets in long term. In Indian scenario, it has been seen that home blood pressure monitoring should be encouraged for patient involvement and compliance. Reliable devices should be used, and home blood pressure monitoring correlates better with hypertensive mediated organ damage than the office recordings. The advantages of home blood pressure monitoring are it distinguishes sustained hypertension from white coat hypertension. Patients are to be encouraged to make morning and evening recordings for 3 to 5 days in home, and a mean of these multiple readings truly reflect the blood pressure. Besides providing real life readings, it also encourages patients' compliance and participation in the management. And home blood pressure recordings are generally superior to clinic blood pressure measurements in predicting long-term prognosis, and it has been shown to significantly predict important endpoints, including all-cause mortality, progression of chronic kidney disease, and functional decline in elderly. In addition, home blood pressure recordings significantly and strongly predict cardiovascular events. So why home blood pressure measurements are preferred over clinic or ambulatory blood pressure measurements? This has been seen in a study in Japan that home blood pressure monitoring has got a better reproducibility, better acceptability among patients, and better repeatability of the blood pressure recordings. If we look into the compliance and adherence part, it is better with home blood pressure monitoring, and also awareness of hypertension, patients' active participation for medication, patients' motivation to control blood pressure, and doctor-patient cooperation and communication is far better in home blood pressure monitoring compared to office blood pressure monitoring. So the next step is, once the diagnosis is correct and you have arrived that the patient is hypertensive, you have arrived on the conclusion, the next step is to start treatment according to guidelines. So there are many antihypertensive drugs available. What should be the ideal characteristic? First and foremost, treatment should be evidence-based in relation to morbidity and mortality prevention. Use a once daily regime which provides 24-hour blood pressure control. Treatment should be affordable and cost-effective relative to other agents. It should be well tolerated. and evidence of benefit of use of that particular medication is to be there in populations to which it is to be applied. So coming to the rationale, why single pill, though combination therapy is advocated nowadays, is blood pressure is sustained by multiple interrelated mechanisms. Due to resetting of the set point, when blood pressure is lowered by blocking one pathway, other pathway gets activated to compensate. Therefore, it would be logical to block multiple pathways at the same time to effectively lower raised blood pressure. So, if we look into the practical necessity of combination therapy, it has been seen that in monotherapy, just 10 to 30% of the patients are adequately controlled, whereas aggregate of available data suggests that at least 75% of the patient will require combination therapy to achieve required blood pressure targets. Various trials have again advocated the need for multiple drug therapy, and which is far better than monotherapy. So even Indian guidelines suggest, which has been published in 2019, that majority of patients need more than one agent for control of blood pressure. Combination therapy in single pill is encouraged for better compliance. So preferred use of two drug combination therapy for the initial treatment of most people with hypertension, which should be a single pill, and preferred use of ACE inhibitor or ARB combined with calcium channel blocker or a thiazide-like diuretic is the core treatment strategy for most patients, with beta blockers reserved for specific indications such as angina, MI, or others. We all know the target should be less than 140/90. First is lifestyle behavioral changes, and even with these lifestyle changes, blood pressure is not well controlled. Then we should initiate with ACE inhibitor, ARBs, calcium channel blocker, depending on the drug which suits particular patient. Along with you can combine it with a second drug. Again, stressing the need for combination therapy, a meta-analysis suggested that though till now, monotherapy has been the standard initial treatment for reducing blood pressure, with stepwise increase in dose if the desired decrease in blood pressure is not achieved. But nowadays, combining drugs from different classes is approximately 5 times more effective in lowering blood pressure than increasing the dose of a single drug. And hence, combination therapy is the preferred initial strategy in the treatment of high blood pressure nowadays. Again, these various trials suggested that combination therapy is a lot better than monotherapy for treatment of hypertension. So if we look into the compendium of the pathophysiology and treatment of hypertension, so two drug combination, the rationale for its use is that greater blood pressure reduction versus monotherapy, steeper dose blood pressure response relationship is seen. However, there is no or small increase in hypotension episodes. More frequent and desired blood pressure control is achieved, better adherence and compliance to drug treatment, and reduced therapeutic inertia is seen with combination therapy. One more important finding in hypertension in Indians particularly is that Indians have higher average resting heart rate. So if we look into the real world Indian evidence, most of the Indian hypertensives are non-deepers. Non-deepers means that like usually systolic and diastolic blood pressure decreases by 10 millimeters or more during night hours. But in Indians, most of the time they are non-deepers and it does not decrease by 10 millimeters of mercury. They have OSA and they have high resting heart rate, hence proving that Indian hypertensives are sympathetically overactive. One study has shown that prevalence of sympathetic overactivity in newly diagnosed hypertensive patients in India is around 62%. Now, like nowadays, most of the time we have been using ACE inhibitors, ARBs, and calcium channel blocker as first-line drug in monotherapy or combination therapy. So there has been concern regarding the degradation of beta blocker use in hypertension guidelines. So is the time and the monopoly of beta blocker is over in hypertension treatment? Not necessarily, I would say. because even beta blockers reduce blood pressure to desired level of more than 140 to less than 140/90. There is also prevention of new onset heart failure and coronary events and regression of left ventricular hypertrophy. Overall, as I stressed, that Indians are like their resting heart rate is much higher than Western counterparts. So a heart rate of 70 beats per minute is desirable in all hypertensive patients, and which can be achieved very well with the beta blockers. So beta blockers reduces heart rate, reduces LV contraction, and hence reduces blood pressure. Now coming to the positive lusitropic effect of beta blocker. What is that lusitropic effect? Selective beta-1 blocker like metoprolol have a great deal, and they achieve positive lusitropic effect by reducing myocardial force and contractility by selectively blocking beta-1. However, beta-2 receptor remains unblocked and provides relaxation to myocardium and also dilates blood vessels supplying skeletal muscles, which leads for heart to have more time to actively relax, which is known as positive lusitropic effect. So as and when required, beta blockers are also a good drug and should be used. Now, again, combination therapy advantages are multifold, as I stressed: improved compliance, fewer pills, it offsets the side effect of a single drug, additive action, effective blood pressure control, and also shorter time to achieve blood pressure control with increased efficacy of drugs. So key message would be single pill combination and home blood pressure monitoring. If we are using these two things, home blood pressure monitoring if possible and single pill combination therapy, then hypertension would be more effectively controlled and there would be less chances of hypertensive mediated organ damage, which we see in long term. Thank you.
Thanks a lot for a very good talk and knowledgeable talk, Dr. Ajay Sharma sir. And now we'll be switching over to the second session, which will be delivered by Dr. Vishal Kastwar, and he's a very eminent and well-known diabetologist from Jabalpur. And he'll be talking about the diets, right? Vishal, prescribing exercise for diabetes. What are the various exercises which are fruitful in diabetes management and which can reduce the burden of complications associated with diabetes? So over to you, Dr. Vishal Kastwar.
Yes, thank you, Abhishek, and thank you, Ajay Sharma sir, for this nice presentation on the dilemma of hypertension. I'll be taking you through some important aspect of diabetes management, and it is one aspect of diabetes management which has always been thought to be very important. But clinicians or researchers have not really given a proper heed to it, and that's why exercise, although is recommended to all diabetic patients, but is never ever prescribed properly. At most, what we do is we tell our patients to, let's say, walk or maybe run or maybe jog or maybe do any kind of exercise for 30 minutes in a day. But what exercise would be suitable for which person has never been discussed. So this is kind of a new presentation, and I welcome you all to this new presentation by this ADA position statement, which was published in Diabetes Care, which has said that adoption and maintenance of physical activity are critical foci for blood glucose management and overall health in individuals. So again, they are talking about physical activity. And what is physical activity? Physical activity includes all movements that increase energy use, while exercise is a planned and structural physical activity. So you can advise your patients to do physical activity, but if you are talking about exercise, it has to be a structured activity which has to be advised to your patients, which will reduce cardiovascular risk factors, contribute to weight loss, improve the overall well-being, and overall result in improved compliance and improved glycemic control of your type 2 diabetes mellitus patients, not only physically, but also mentally. What exercise does, if you have a working muscle, the glucose usually enters into the extracellular tissue, and when the muscle is working, there is increased blood flow, resulting in increased capillary recruitment. Then the glucose crosses the membrane, and when the exercising muscle is there, there will be an increase in transporter activity, and this goes intracellularly and results in formation of glucose 6-phosphatase, and then it is utilized gradually. So what are the usual recommended exercise? We have aerobic exercise, which includes walking, then cycling, jogging, skipping, climbing stairs, dancing, swimming, and skating. These are all aerobic exercises which can be recommended to people according to their interest and maybe rotationally for a few of them. And the next kind of exercise is resistance training, which includes free weights, weighing machines, and body weight exercises, which are known as calisthenics, and using elastic resistance bands. Then apart from the aerobic and the resistance exercises, we have the other forms of exercises, which include flexibility exercises, improving the balance exercises, and activities like Tai Chi and yoga. These are 3 kinds of exercises, but apart from these exercises, there is a specific recommendation on reduction of sedentary time. And all adults, particularly those of type 2 diabetes, should reduce the amount of times they are spending on their chair or on their couch. If you have a prolonged sitting of maybe continuously around 30 minutes, then all adults and specifically of type 2 diabetics should do simple stretching, moving about, or anything that requires movement of most muscle groups of the body for a period of 2 minutes. Every 30 minutes, if you have been sedentary, you have to move for 2 minutes. So what are the benefits of different kinds of exercises? Aerobic exercises, resistance training, and the different kind of exercises all have different benefits. Aerobic exercises result in increased mitochondrial density, insulin sensitivity, oxidative enzymes, improved lung function, improved immunity, and result in improved cardiac output. And the resistance training exercises, which are those with weights or body weight or elastic resistance bands, help in improvement in muscle mass, body composition and strength, physical function, mental health, BMD, insulin sensitivity, and the other important parameters like blood pressure, lipid profile, and cardiovascular health. Overall, both aerobic training as well as resistance training result in improvement in insulin signaling and improve insulin sensitivity. Resistance training, in addition, results in improvement in the lean body mass, improvement in muscle mass. Finally, improving the insulin sensitivity and decreasing the metabolic syndrome. If you remain sedentary, there is a high likelihood of reducing insulin sensitivity and insulin secretion that can lead you to gradual development of prediabetes and diabetes. But exercise can result in improvement in insulin sensitivity and thereby improvement in glucose tolerance. There are other kinds of exercises that we just discussed. What are their benefits? Limited muscle movement, limited joint mobility, and muscle stiffness are usually present in a lot of diabetic patients and is one of the important complications of diabetes because of the formation of advanced glycosylation end products. Stretching increases muscle movement around joints and improves flexibility, preventing knee and shoulder complications specifically, and overall reducing the stiffness of the body. Group exercise interventions with resistance and balance training like Tai Chi can reduce the falls by 28 to 29% as shown in various literature. And Tai Chi training can also improve glycemic control, balancing, neuropathic symptoms, and some dimensions of the quality of life. If you look at the recommendations for type 2 diabetes in adults regarding physical activity, adults should perform both aerobic as well as resistance training exercises. And adults more than 70 years of age are specifically instructed to add on flexibility and balancing exercises to their schedule. Structured lifestyle intervention should include at least 150 minutes per week of physical activity. And this is a recommendation that comes from the Western literature. For Indians, the recommendation says that 30 minutes daily of exercise is required all 7 days in a week. Dietary changes alongside exercise should result in a weight loss of 5 to 7%, which is the recommendation. Children and adolescents are recommended to do a similar exercise as is recommended for the adults. And daily exercise should not involve more than 2 days of vacations in between. improve insulin action. Regarding exercise training, we should know the type, intensity, duration, frequency, and progression. So types we have just discussed: aerobic, resistance, and flexibility exercises. Regarding intensity, for aerobic exercise, light exercise is not recommended. So moderate to vigorous exercise is recommended, and similar is the case with resistance training. Moderate exercise for resistance training means 15 repetitions of an exercise which you cannot do for more than 15 times. And vigorous exercise means if you are not able to do more than 6 to 8 repetitions of that exercise, and you have to do 6 to 8 repetitions of that exercise, that makes vigorous exercise. For flexibility and balance, the intensity means stretching to a point of feeling tightness or very slight discomfort. Balance exercises of light to moderate intensity should be done. If you look at duration, 150 minutes per week is what I have already told you. For adults who are able to run steadily at a speed of around 10 kilometers per hour, they should do it for 25 minutes. And if you are able to run for 10 kilometers per hour for 25 minutes, then the recommendation is reduced to 75 minutes per week, because this forms vigorous activity. When you are doing resistance exercises, it means doing 8 to 10 exercises of the resistance type, 1 to 3 sets of repetition of 10 to 15 repetitions to near fatigue per set on every exercise early in the training. And for flexibility, the duration is holding static or doing dynamic stretch for 10 to 30 seconds and 2 to 4 repetitions of each exercise. If you want to understand the frequency is aerobic exercises have to be done for 3 to 7 days in a week. If you are mixing them with resistance training, you can reduce the number of days of aerobic exercise and mix with resistance training. Resistance training should involve at least 2 non-consecutive days, and if it is possible, you can do 3 non-consecutive days. For flexibility and balance, which is recommended for people aged more than 70 years, they should do flexibility and balance exercises for more than 2 to 3 days per week. And it is not that same exercise can be continued at same intensity for a long period of time. Whether you are doing aerobic exercise or whether you are doing resistance or flexibility exercise, you should try to progress gradually. The beginning training may involve moderate intensity of aerobic or resistance training exercises, but gradually increment should always be done to sustain the benefit obtained. Otherwise, the muscles get used to a particular form of exercise and then the benefits are not obtained to that extent. For pregnancy, there are specific recommendations which include that women who are having pre-existing diabetes of any type should be advised to engage in regular physical activity prior to and if not contraindicated during pregnancy also. Pregnant women with or at risk for GDM should be advised to engage in 20 to 30 minutes of moderate intensity exercise on most or all days of the week if not contraindicated, that is, if they are not advised against it because of obstetric considerations. There have been studies in which supervised and non-supervised trainings have been compared, and it has been found that supervised aerobic or resistance training reduces A1C in adults with type 2 diabetes, whether or not they include dietary co-intervention. But unsupervised exercise only reduces A1C with an additional dietary intervention. Similarly, individuals who are taking a supervised aerobic and resistance exercise usually achieve improvements in A1C, BMI, waist circumference, blood pressure, overall fitness, muscle strength, and HDL cholesterol. This is probably because supervised activity constantly involves a gradual escalation of the activity when you have a properly trained trainer training you. Considering the adverse events in people with exercise-related adverse events should also be discussed with your patients, and the adverse events include hypoglycemia. Exercise can actually result in hyperglycemia also because of excessive glucose release from the liver. Medication adverse effects have to be discussed. Heat-related illness during physical activity during summer, and orthopedic and overuse injuries should be explained to the patients properly before letting them do any kind of exercise. Regarding hypoglycemia, there are recommendations that if the pre-exercise blood glucose level is below 90 milligram per deciliter, then the subject should ingest 15 to 30 grams of fast-acting carbohydrate before starting physical activity. And the activity should be brief in duration for less than 30 minutes. For pre-exercise blood glucose level between 90 to 150, you can start consuming carbohydrate at the onset of most exercise, depending on the type of exercise and the amount of active insulin. For glucose levels between 150 to 250, exercise should be initiated without consumption of carbohydrate, while if the glucose levels are beyond 250 milligram per deciliter at the onset of exercise, you should test for ketones. And if there are ketones in the urine, exercise should not be done, because exercise can result in increased ketonemia and finally lead to ketosis. As regards pre-meal bolus insulin is considered, if the patient is exercising within 90 minutes of giving the insulin dose, then the patient should reduce the insulin dose before the meal. And if the patient is doing mild aerobic exercise, the reduction of insulin dose should be by 25% if the exercise duration is 30 minutes, and by 50% if the exercise duration is 60 minutes. For moderate aerobic exercise, for moderate and heavy exercise, an exercise duration of 30 to 60 minutes, there should be more reduction in the amount of pre-meal insulin that the patient is taking. If you look at exercise recommendations in relation to drugs, we have just discussed insulin. Even for insulin secretagogues, if the patient is exercising after taking insulin secretagogues and the insulin secretagogue dose has been recently can occur. Monitoring is recommended to prevent this hypoglycemia, and dose adjustments have to be made accordingly. For metformin, thiazolidinediones, DPP-4 inhibitors, GLP-1 receptor analogs, and SGLT2 inhibitors, usually no exercise considerations is required, but for SGLT2 inhibitors, increased fluid intake is recommended. And for thiazolidinediones, exercise can actually result in a higher amount of fluid retention, and this has to be taken into consideration if the patient is taking these particular drugs. For non-diabetic drugs, if the patient is already on beta blockers, then he may have hypoglycemia unawareness during exercise. Not only this, beta blockers can actually reduce the exercise capacity also. So checking glucose levels before and after exercise is recommended for people who have just recently introduced beta blockers or increased the dose of beta blockers. For other agents, regular exercise training can reduce the blood pressure during exercise and in the post-exercise period. So the doses of blood pressure medicines, hypertension medicines, may need to be adjusted for people who have recently started exercising on the basis of monitoring. Dyslipidemia drugs like statins can lead to muscle weakness, discomfort, and cramps in minority of users. But otherwise, they are generally safe and no dose adjustments are recommended. For fibric acid derivatives, there is a rare possibility of myositis or rhabdomyolysis, and risk is higher with gemfibrozil statin combination. So if these complications are present, then exercise may be avoided, or if there are any symptoms, we can do CKMB testing before starting exercise. For specific complications with diabetes that some people might be suffering, if the patients are suffering with vascular problems, exercises can be undertaken safely but should be gradually adjusted, and you may require a pre-exercise testing like TMT before recommending exercise to that particular patient. For patients with peripheral neuropathy, proper foot care needs to be explained to your patients, because neuropathy can lead to foot problems. Proper foot care to prevent, detect, and prevent the problems, avoid ulceration and amputation are important. For people who have diabetic retinopathy, jumping, jarring, and head-down activities and heavy breathing activities or breath-holding activities should be avoided. For patients who have kidney disease, exercise has not been found to accelerate the progression of kidney disease, but you have to take care of prevention of ketonemia. Patients who have diabetes-related orthopedic limitations should do regular stretching and appropriate progression of activities gradual progression of activities should be explained to the patients to prevent further joint injuries. Concluding, physical activity and exercise should be recommended and clearly prescribed to individuals with diabetes as far as possible. Recommendations should be tailored to meet the specific needs of each individual. Daily sedentary time should also be reduced alongside exercise recommendations, and behavior change strategies can be used to promote the adoption and maintenance of lifetime physical activity. Patients who do regular physical activity have been found to be more motivated towards a better diabetes management. And those patients who do not do regular physical activity have been found to have adverse outcomes, not only related to the lack of exercise, but also in relation to lack of motivation. Thank you.
Thanks a lot, Dr. Vishal, for such a nice presentation. Thank you. And any questions from the audiences? I don't think so. Right. I don't think any questions, right?
Just give me 1 minute, sir.
Yeah.
So, Abhishek, there are specific recommendations regarding exercise, but do you think there are any specific recommendations regarding glucose monitoring in type 2 diabetes mellitus patients? How do you recommend monitoring to your type 2 diabetes mellitus patients?
Vishal?
Abhishek,
Yeah.
do you recommend exercise to your diabetic patients?
Yeah, certainly. See, your presentation was extremely well planned, because basically we as a physician don't tend to bother more upon the exercise. So basically now, like looking at your presentation, we'll be like more prompted in prescribing medications with exercise. Basically the confusion lies where how much to prescribe the exercise time or values, or how much limitations are there basically in exercises, that we have to take care of it. And looking at your presentation, it's like well clear right now how much and at what intensity we require exercises just to bring the glucose variability down to a normal level. But just one more question, Vishal. If a patient like basically is on a beta blocker or basically alpha blocker, what kind of exercise do you recommend? Because on a chronic use of beta blockers, be it metoprolol or be it cardioselective blockers also. So like vigorous exercise or high intensity exercise are recommended or not?
See, there are, as regards exercise is concerned, there are two issues with beta blockers. Beta blockers otherwise are very good drugs, and they prevent heart attacks, and even during heart attacks they reduce the amount of the infarct area. So they are very good drugs and should be prescribed as far as possible to most diabetic patients. This is what I believe. But regarding exercise, beta blockers can really reduce the understanding of hypoglycemia. They can cause hypoglycemia unawareness, because hypoglycemia results in sympathetic response. And beta blockers block that sympathetic response. So for patients who are on regular doses of beta blockers and they have been doing whatever exercise that they have been doing regularly, there is no problem. But if you have just suddenly introduced beta blockers, or maybe that you have increased the dose of your beta blockers, you should explain to your patient that intermittently they should keep on checking glucose levels before and after exercise, so that they know what's happening on hypoglycemia front. And secondly, beta blockers can reduce the chance of you having a higher heart rate. So because if you are not having that higher heart rate, there can be reduced cardiac output overall, and this reduced cardiac output can result in a higher amount of fatigue and can result in reduced perfusion to important organs like myocardium, kidneys, and retina just after exercise. So if the patient has been continuously on a particular beta blocker therapy and he is continuously exercising, there is no problem. Again, if the patient is just starting exercise and he is on a beta blocker therapy already, or maybe we are increasing the dose of beta blockers, then we should give specific recommendation to our patient that he should actually increase the exercise gradually and he should not over exercise on any particular day. A lot of people do a small amount of exercise 6 days in a week, and they do vigorous exercise on Sundays. Maybe they do go on outing and they do vigorous exercise. So if they are on beta blockers, specific recommendations against doing this kind of activity should be given to the patient, specifically if they are diabetics, because this can not only lead to hypoglycemia, but this can lead to cardiorenal and retina problems also.
That's very good. That's good. That's good. Okay. So should we end now?
So I think high class people have also gone out or what?
So very nice presentation by Dr. Ajay Sharma sir and Dr. Vishal Kastwar also, and it's been very hot topic. The exercise which we are like onto right now, we should basically focus on exercise and diabetes both simultaneously, how to get it controlled and reduce the complications. So thanks a lot, Dr. Vishal, for such a nice presentation, and we'll be hoping that we will meet again.
Yes, definitely.
Thanks a lot. Thank you.
Sir, there is one question from audience. Sanjeev Jaswal sir asked that if you have to advise one exercise for diabetic patient, which exercise would you advise to your patients?
See, if you want to do just one exercise, it can be one exercise on different days. So let's say if the patient is doing walking on 2 days in a week, then he should shift to some other exercise, maybe jogging, maybe yoga for another 2 days. And for the remaining 2 days, he should do some weight exercises. Maybe he can take a small weight of 1 or 2 kgs and do weight exercises, or maybe he can do calisthenics also, where he can do body weight exercises like sit-ups, push-ups, whatever is possible. So it cannot be a single exercise being done for all 6 days in a week, because the benefits tend to be lost over time. If you keep on doing the same exercise on a daily basis, we have patients who have been walking 30 minutes for, let's say, for the past 2 years or so. But the benefits that they were to be achieved, that they were achieving with walking, were reached maximum at the end of maybe 1 month or 2 months. Unless you keep on accelerating the amount and intensity of exercise, and unless you add resistance or flexibility training exercises in between, you are not going to obtain the required benefit from exercise. A single exercise for all days is not advisable as far as clinicians are concerned and diabetologists.
That's great. So very nice presentation. Thanks a lot, Dr. Vishal.
My personal thanks to High Glance people for arranging this webinar. And if there are no more questions, we can just take leave.
Thank you.
Good evening, everyone.
Yeah.
Good evening, everyone.
Good evening.
Yes, sir, we can hear you.
Good evening, everyone. Good evening, everyone. I, Shalam Namdev, on behalf of High Glance Laboratories and the entire participants, extend a very hearty vote of thanks to both speakers and the coordinator for gracing this evening and sharing their valuable insights with us. We would like to thank our international doctors and team who participated today in spite of different time zones and the celebration of Christmas. We are also grateful to all participants for being a part of webinar and our support team, as well as colleagues of both divisions whose efforts made this webinar a successful event. Wishing you all Happy New Year in advance. Thank you once again. Thank you.